I'm Dr. Ted of Jefferson Orthopedics, and this is Fracture Friday. The basic concept is that I try to go over a topic that I find interesting in orthopedics. It may be a fracture, it may not. If there's something that you would like to hear about, or there's a topic that you would like to learn more about in orthopedics, which is the study of the musculoskeletal system, please comment below and I'll try to do a video for you on that. I'd love to, actually. So, this week we're going to talk about an open forearm fracture. Now, we did a video 3 weeks ago on an open forearm fracture, and this is again a video on an open forearm fracture, but this fracture shows some of the problems that occur with forearm fractures, and it further clarifies some of the open fracture classification stuff that I mentioned in earlier videos. So I will go over that again, but I apologize for the redundancy of the videos, but I think this is interesting and I think you'll find it interesting. So, this is actually a two-bone forearm fracture, open, that was sustained by the patient getting their hand caught in a hay baler, which sounds like something out of a Stephen King novel to me. It just sounds horrible, but I've never used a hay baler, so I don't know what they do, but they apparently can really break your arm. So, this patient has what we would classify as a grade 3 open two-bone forearm fracture. And more specifically, it's a grade 3 open comminuted midshaft two-bone forearm fracture. Okay, so what does all that mean? Well, grade 3 open, it's classified that way because it's a farm injury. Because it happened with farm equipment, the bacterial load with the bone being exposed to the external environment goes up, so we classify it as a grade 3. So grade 3s are typically where there's a laceration or a puncture wound that's greater than 10 centimeters in length, or if it's a farm injury, or if it's present for more than 8 hours before the patient seeks medical help at the hospital. So he presented to the ER way before 8 hours. His lacerations were he had 2 on the dorsal aspect, the back of the forearm. The dorsal aspect of the forearm is here. The volar aspect of the forearm is the palm side of the forearm. The radius is the bone on the thumb side of your forearm, and the ulna is the bone on the small finger side of your forearm. So he broke both of those. Now when he broke both of those, the bone penetrated the dorsal aspect of the forearm. So there was about a 1.5 centimeter laceration over the back of his forearm where the radius is, and another 1.5 centimeter laceration over the ulnar aspect of his dorsal forearm. So that's really only 3 centimeters. So that by definition, it should be a grade 2, but because it happened in a farm setting, it's automatically classified as a grade 3. So that's one of the things that I was talking about why I think this is interesting and why we should go over this fracture. So, the other thing that's interesting is when you look at these preoperative X-rays, you can see that it's open, you can see that the bone is sticking out through the skin, if you've ever looked at X-rays, but it's also comminuted, meaning that the fracture on the radius, that's the bone on the thumb side of your forearm, is broken into more than just 2 pieces. It's broken into actually 4 pieces. So comminution means that there's multiple fracture fragments. So that creates multiple interesting treatment problems or scenarios. One is that it's open, so we have to worry about the bacterial load and we have to worry about making sure that the fracture doesn't get infected. 2, we have to worry about the soft tissue stripping that occurs because of how far those bones had to travel to become open. And 3, we have to worry about the number of pieces that it's broken into, because that's obviously more bone that the body has to heal, so therefore it's harder for the body to heal that much bone, so it increases the risk of what we call a non-union, meaning that the fracture is fixed adequately, but that the body fails to unite the bone back into one solid piece of bone, which is obviously the treatment goal for everything that I do when it comes to fractures, is that we want to take something that was whole and is now broken and make it whole again. Okay, so we use plates and screws to do that, and that's what we did here for this patient. We took them directly to the operating room and we washed out the wounds and cleaned them up, and then we did open reduction internal fixation, which is the medical term for we make a skin incision. For the radius, we make a skin incision on the volar aspect of the forearm. Then we go in there and openly reduce, meaning that we're now looking at the bone. We've made the skin incision, we've opened up the bone to look at it, and we reduce it end to end, or in this case, we reduce it end to little pieces to end, because that's the way the fracture kind of worked, and then we put a plate on it to hold it there. So it's kind of interesting when we look at the radius, and I like to stick on that for just a minute, because this is actually a bridge plate, which is another interesting concept in orthopedics, because there's 3 screws distal to the fragment. Now distal is another term I should probably explain, means down by away from the center of the body, or down by the wrist, and proximal is towards the center of the body, so it's up towards the elbow. So distally, we have 3 screws. Then we have a gap because of this bridge plate concept, and then we have screws proximally, another 3 screws. So it bridges that bone gap where those little pieces are broken, and we kind of, I call it key them back in. It's like putting a puzzle back together. So you try to wedge those little pieces of bone back in there so they'll stay in there. So, and that has been successful, I can tell you from follow-up x-rays for this patient in the office. So that's a bridge plate, and I think that's kind of interesting, and that's another reason I wanted to go over this open fracture again. And then we make another incision over the ulnar aspect of the forearm and put a second plate over that. So that's more of a transverse fracture. It went straight through. So you see 3 screws and then 3 screws, and the fracture's right in the middle. So that's not a bridge plate or any of that stuff. But it's very interesting because these things, or some of the stuff I didn't go over before, some of the problems we run into in forearm fractures is what's called a synostosis, which means those 2 bones heal, where they used to be 2 separate bones, they have a bridge of bone that connects the 2. So now you have 2 bones that used to move for what we call supination, like holding a cup of soup, or pronation, where we turn the cup down, is the way the forearm moves, and that happens because there's 2 bones in there. If those 2 bones fuse together, which is called synostosis, then you lose all of that. And that happens if we try to put both plates through 1 incision. So that's why the recommendation is for 2 separate incisions. And I thought that was something else that I failed to mention last time that I thought you might find interesting. Hey, Dr. Ted again. Don't forget to like and subscribe to our page. And by the way, if you'd like, please make comments at the bottom. I'll try to answer any comments that you may or may not have at the bottom as soon as I can get to it. And if you have any topics you'd like to hear about in the future, maybe you have a family member that sustained an injury, maybe you had an injury and you'd like to learn more about the general principles behind this treatment of said injury or said problem, then send me a message and I'll try to do a video about that in the future. Thanks for watching.